Hi everyone, my name is Vlajison. I'm a third year MLS student, and I wanted to share a little bit about how we in the lab would go about testing and treating Darryl's health. So in this presentation, I'll bring you along the general stages a collected biopsy specimen would go through from collection to diagnosis. Then I'll go into the primary department that we would detect Darryl's cancer, which is the anatomical pathology department. In this lab, we do testing that includes collection, grossing, embedding, cutting, and staining. Lastly, I'll talk a little bit about supporting laboratory departments that play an important part in ensuring Darryl is given the best chance at a successful treatment outcome. So a little rehash on Darryl's situation. Biopsies were received from an enlarged tongue lesion that had grown significantly and painfully since his last checkup. This ultimately led to the diagnosis of a squamous cell cancer of the tongue. So how exactly did this happen? There's generally 3 stages of professions that this sample will go through on its way to a proper diagnosis. First, there is the patient whose tissue is collected, usually by a clinician or a surgeon. In Darryl's case, this was probably an ear, nose, throat specialist or a dentist with specialized training. Second, the sample will go to us lab techs in the anatomical pathology department, where all the histopathological preparation and testing will take place. Lastly, the pathologist. This is the head honcho that finalizes a medical diagnosis given the information provided by the lab tech's prepared slides. Collection. After the tongue lesion was assessed, which was likely done by a dental hygienist, Darryl undergoes a tongue biopsy. This can be done in a few locations. Most likely Darryl had it done in either a doctor's office or an outpatient clinic. Other places that collection may occur include operating rooms, or if the patient is deceased, an autopsy site. Once the biopsy is collected, it is placed in a neutral buffered formalin solution where it can be transported and stored to an anatomical pathology lab. Different fixatives, or even no fixatives at all, may be used if other specialty testing is ordered. It's worth it to note that during this entire process, various clerical checks are performed, where we make sure to match Darryl's identity with any and all markers on the specimen and its container, like the Unique Lifetime Identifier, or the ULI, or the PMRN, along with others. Grossing. After Darryl's biopsy has been received in the AP lab, the tissue is oriented, which is most important in identifying which areas are most likely to detect a neoplastic process like cancer. This will vary dependent on the amount of layers and the organ or tissue type. The tissue is also dissected. This is where we would assess the physical characteristics of the specimen in color, dimensions, weight, etc. If it's small enough, like in the case of Darryl, it may be submitted in full. Or it can be sectioned into a small piece that the tech determines can represent the entire specimen. The tissue will then be placed in a cassette. The prepared tissue is placed inside of a color-coded cassette, in which it will be labeled with important patient information to correlate the specimen to a patient. We can see these cassettes in the photo as the bright pink rectangular objects. In the time it is without any of those identifiers, it's at the highest risk of being misidentified. In the worst case, this may cause a false diagnosis. The tissue will then be sent for processing. After the cassettes are filled, lids will be secured and placed back in fixative and is ready for embedding. Embedding. Most routine histolabs have automated methods that prepare the tissue prior to cutting. After this automated step, the tissue will be impregnated with paraffin wax, oriented inside of a mold in such a way that makes it easy to cut against the blade during the microtomy step. Improper orientation may cause pathologists to miss an area of interest entirely. The embedded tissue will then be cooled on a cold plate until it is completely solid. Cutting. Cutting or microtomy often uses a rotary microtome to cut these embedded paraffin blocks. This instrument will continuously move the tissue microns forward as it brings the blocks up and down across the disposable blade. Cutting is an art, and it largely affects the quality of slides received by the pathologist. If done improperly, it can cause catastrophic waste of sections of tissue that may have important diagnostic information hidden inside. Factors that can affect the quality of your cuts include cutting speed, ribbon handling, water bath temperature, section retrieval. And by water bath, that refers to a process where we take these thin sections, place it in water, and use it to keep the section flat as we bring a slide underneath and catch the section on top of it. At the very top of the slide, you can see a clean cut of a tongue biopsy that we might see in Darryl's sample. Underneath are 3 examples of visual errors that might result from improper technique and comparison. Staining. When we stain a slide, we aim to provide contrast between structures and visually label areas of interest. The most common staining technique that we do is hematoxylin and eosin staining, which is fast and can demonstrate a wide variety of tissue. Specifically, in the case of Darryl, once cancer was suspected, immunohistochemistry staining was ordered as a follow-up. This type of staining uses antibodies to super-specifically demonstrate the elements of interest like in cancer. However, it's very prone to false positives and negatives. In the top slide, we see that very same tongue biopsy that I showed before, which is a beautiful example of that hematoxylin and eosin stain. Underneath is an example of something we'd see in an immunohistochemistry stain, and the other 2 on the right are other examples of special staining that we may do in the lab. Once stained and fixed onto the slide with resin, the slide undergoes some final quality checks and is ready to be sent to a pathologist for assessment. In this case, after Darryl's stained specimen slides were received, Darryl's pathologist diagnosed him with squamous cell carcinoma of the tongue. Other lab testing. Outside of the AP lab, Darryl has begun treatment for chemotherapy. Often, patients undergoing this intense treatment get multiple routine tests to ensure the success of the treatment, how their bodies might be affected by the chemotherapy, and to adjust dosage as treatment progresses. In the hematology department, we'd be doing frequent cell blood counts and differentials to determine if the chemo is affecting your bone marrow or blood cell production. And in the chemistry department, we'd be doing a wide variety of renal and liver function assessments by testing certain analytes and detecting abnormalities. This would about sum up the MLS side of Darryl's treatment. So I hope you enjoyed it, and please let me know if you have any more questions.